We have our first speaker today is Dr. Andres Deik from Penn Medicine, and he will be speaking about what it looks like to provide multidisciplinary care for PSP, CBD, and MSA. Thank you so much for being here. Very good.
Thank you for having me. Good morning, everybody. I love to see this room so full of people. It's great that you guys all made the trip. Hopefully this will be worth your while. I'm just going to speak for a few minutes about multidisciplinary care, what it is, and how we approach it at Penn Medicine. We very much believe in this concept of multidisciplinary care and the importance of delivering care in a systems and team-based approach, much more so than in a siloed kind of perspective. So just bear with me for the next few minutes. And I guess I can advance my slides with this. There we go. Let's see. Oh, look at that. So it's really been a paradigm shift, I think, for the last 20, 30 years in medicine, and particularly in the management of chronic diseases. We understand that it's very difficult for one physician or one provider to really take care of all the aspects of these very complex diseases. When you think about the doctors in the 1940s and the 1950s who would do house calls and would kind of take care of every aspect of a patient's care, medicine in 2021, 2022 is very different. Now we have highly subspecialized specialties, and every one of these different specialties really focuses on taking care of one or more aspects of a certain condition. And it's a trend throughout the world, but certainly here in the US, it's something that we see a lot. So this idea of the jack of all trades is really not valid anymore. I think now we operate in a different model. The model now is that we understand that it is very difficult for one physician to really be able to take on all the different challenges and all the different needs that patients have, particularly patients living with neurodegenerative conditions. We have very much embraced this concept of a team, of multidisciplinary care, of the different modalities and the different aspects within the condition that affect patients and the different ways that we can help them. And we realize that many of these providers are not necessarily physicians. So our teams consist of physical therapists, occupational therapists, speech therapists, social workers, palliative care physicians, cognitive physicians, psychiatrists, and the list goes on and on. And we do really firmly believe that operating in this system where everyone kind of takes a little piece of their expertise and tries to look at these patients through these lenses and try to help them through what they know very well to manage really is in the best interest of patients. And there is some research to suggest that these models, in fact, do provide much better care than when one physician is the one who kind of takes on the role of caring for all the aspects of the patient. So I'll tell you a little bit about that. So in different specialties, in different neurological specialties, this has been shown to be beneficial. So in stroke, for example, there is evidence that patients who undergo multidisciplinary care, who have had a stroke, actually have reduced mortality, so die less, survive more, compared to patients who are not involved in the care of their stroke and the consequences of their stroke through a team. Something similar might be seen in ALS. ALS is another neurodegenerative condition in which patients lose a lot of mobility, different from PSP, but the end result, of course, similar to the sense that patients become disabled and having care from other family members. And in ALS, it has been shown that patients who are cared in a multidisciplinary fashion may actually survive more. We at Penn also have a multidisciplinary team that runs a clinic for patients with ALS. We are not involved in it. We're movement disorder specialists, and the ALS clinic is run by the neuromuscular specialist. But the idea is the same. The members of the teams are the same. There is a physician, but there's also all these other team members that, as I mentioned, help in the overall well-being of the patient. And then in certain forms of dementia, it actually has been shown that short-term patients with dementia may have less restlessness and less restless behavior. And in the longer term, patients have less social isolation, which of course is a big problem in patients with dementia. So in Parkinson's disease, there has been more studies than in patients with atypical Parkinsonian syndromes like PSP, MSA, or Corticobasal syndrome. And in Parkinson's, some of these benefits have been seen. So in Parkinson's disease, in the outpatient world, the use of a multidisciplinary team has been shown to help with long-term improvements in motor function. So it might actually be that patients who are actually involved in these teams can move better. Short-term improvements in a number of different scores. The UPDRS, some of you might be familiar, is the scale that we use to measure the ability of a patient to move. And there have been seen benefits in UPDRS in patients who undergo multidisciplinary care. Gait speed, stride length. My physical therapy colleagues there in the back can certainly attest to that. Speech, depression, and quality of life in general. In the inpatient setting, so when patients are hospitalized, they're also managed by a multidisciplinary team. And it has been shown that these patients who receive this care have more improvement in pain, in emotional reactions, and physical mobility, and overall quality of life. So very clear and robust data from the Parkinson's world. And again, understanding that Parkinson's and PSP and these other atypical Parkinsonian syndromes are not exactly the same, but you could extrapolate, and some of these findings that you see in Parkinson's, you could perhaps hypothesize that they might actually also be seen in patients with these atypical syndromes. So if this is also from the Parkinson's world, and you can ask yourself, well, why is multidisciplinary care so important? And as you can see here, it really is because there is a wide gamut of symptoms that patients can experience. Of course, there's a motor component. Patients can have imbalance and falls, which of course can also be seen in patients with atypical Parkinsonian syndrome. But there's also all these non-motor symptoms, which over the last 20 years, I think the field of movement disorder has become a lot more sensitive about. And understanding that it is very difficult for one doctor to manage all of these different non-motor symptoms, particularly since many of them can be complicated in different ways, particularly psychiatric symptoms, for example, in patients with Parkinson's disease, or cognitive symptoms. We certainly use the help of our psychiatry and cognitive neurology colleagues who really lend in their expertise and really provide us all the tools that we need to make quality of life the best it can be. Bladder symptoms, also very common in Parkinson's, can also be seen in multiple systems atrophy, for example, and we often rely heavily on the expertise of our urology colleagues. So some data is available for patients with atypical Parkinsonian syndrome. This was an abstract that was presented in 2020. Oh, I'm sorry, there seems to be, okay. You can't really see the conclusion, unfortunately, but I'll tell you what it showed. So basically, they did a review of patients with atypical Parkinsonian syndromes who underwent multidisciplinary care, and they do suggest that perhaps this signal that we see in patients with Parkinson's disease and other movement disorder can also be seen in patients with atypical Parkinsonian syndromes. However, they acknowledge that we do need more work. We need more research to really see those benefits, and this abstract in particular was more of an invitation to engage in that perhaps we need to understand more what are the impacts that multidisciplinary care can have in our patients. So it's really an invitation for research, an invitation to learn more, but it was hopeful in the sense that they did see, oh, there we go, thank you for fixing that, that they think that patients with atypical Parkinsonian syndromes who undergo multidisciplinary care do find a benefit. So how does this work? How do we deliver multidisciplinary care to our patients? And there's very different models. There's different takes on this, and I think each center, with the many CurePSP centers that exist in the country, but really every movement disorder center has their own combination of specialists and has figured out their own way of delivering this care to their patients. There's a few real-life examples here. So this is the model that they use at Mount Sinai Beth Israel, where I did my fellowship training. So I can speak to this because I used to be part of this team. And basically, the way it works is there's a team here. You can see there's one neuropsychologist, a social worker, a psychiatrist. There's 8 neurologists and a full-time nurse practitioner. And the nurse practitioner, actually, if you see in this diagram, really takes a lead role. The nurse practitioner is involved in education both to other members of the team, so the fellows, but also education to patients. This is also a nurse practitioner who is trained in deep brain stimulation programming. So, and this, of course, applies more to Parkinson's patients, but she would actually be able to program these patients as well. And this is this was a nurse practitioner who is also training in counseling. So she actually had a big role in counseling our patients, and those are both patients with typical and atypical Parkinson's. But then when you think of the neurologists, it's both the attendings and the fellows, meaning the neurologists who have graduated but are training to be movement disorder specialists, they were also deeply involved in the care of these patients. And through the different academic medical centers, you see that trainees actually play a pivotal role in being able to manage all of these patients. Here's another example. This is from a colleague of mine who is the director of the center at Cornell, also in New York City. But you can see how they've structured it differently. So at Cornell, they actually have a neurodegenerative disease center, so this big umbrella that encompasses both movement disorders and cognitive neurology. They're both within the same spectrum. And they actually share a lot of resources between the two silos, if you may, understanding that many of these needs on our patients are actually shared between the specialties. The needs that patients with advanced dementia and advanced atypical Parkinsonian syndromes have are actually quite similar. So you can see the different components of the team there. And you can see how, yes, there are doctors, but there's also nurse practitioners, research coordinators, therapists. So it's really a huge endeavor of different people, all of whom lend in their expertise and try to work for the benefit of the patient. Now, there's also models that transcend the hospital. So you can have these models in place that are, of course, limited to the place that you work. But since the pandemic and even before, we've understood that some patients just cannot make it to the clinic. So how do you deliver multidisciplinary care for those patients who just don't have access to your resources? And there's two different examples here. I hope they show. This is one example. So this actually is a telemedicine clinic that was created before the pandemic. Nowadays, telemedicine, everybody knows what it is. We've all had to do it since COVID-19. But it turns out there's this group in Rochester was working on this idea back since the early 2010s. So this publication is actually, I believe it's 2015, yes. And you can see what they did here. So patients would actually, so it started because there wasn't at the time, and I believe now there's only a few, movement disorder specialists in the state of Delaware. And the idea was, well, how can we deliver movement disorder care in a state that doesn't have a specialist? And the idea came up, well, why don't we use telemedicine? And you can see here that the clinic was actually in 3 different places. So in Delaware per se, and I believe this was in Dover, but I could be mistaken, and I believe it's the University of Delaware. The University of Delaware had local staff, nurse practitioners, physical therapists, and speech therapists who were physically there. The movement disorder specialist was based in Rochester, New York. And then other resources were based in Central Jersey. And what they would do is that the patients would drive to Dover, would get checked in, and they were seen remotely by the different people who were in different states. So of course, licensure there becomes an issue, right? Like the only way you can do this is if you're licensed in the state you're practicing. But that's a hurdle that is really not difficult to surpass. So the way they worked is they actually were able to deliver multidisciplinary care out of state using a software. Nowadays, there's Zoom, there's Teams, there's BlueJeans, there's so many. But at the time, there wasn't. So they actually had to create from scratch this software to be able to deliver this time-to-time, like face-to-face through the video care for patients in a state that didn't have this resource. So really a fantastic and ahead of its time, I would say, publication. And nowadays, we think of it, and it's so common to have telemedicine. But at the time, it was kind of revolutionary. So you can see here a scheme of how it works. So the patient comes in. They get checked in. The nurse practitioner starts in and starts going over symptoms, motor and both non-motor. And then once all those symptoms were collected, to maximize or to make the most out of the time that the physician was seeing the patient, the physician would log in already kind of knowing what the issues were because they were being transmitted by the nurse practitioner. Then once the physician finished, then the patient was seen by the research team. They had clinical trials going on at the university that the patient could then become eligible for. And then they would schedule a follow-up and be seen, and a report of the different findings was sent to the patients. So it can really be made work even when the patients cannot get to the doctor. As long as there's other members of the team, now, of course, we have the technology to do this remotely. Here's another example. This is a publication from one of our former fellows, Jury Fleischer, who is now in Chicago. And they came in with this clever model of, well, what if patients are homebound? What if they can't really get out of the house? And I will make the caveat that this is Parkinson's disease, not atypical Parkinsonian syndromes. But again, the needs are very similar. And what they did is they created this mobile, multidisciplinary team, small team a social worker, a doc, and a nurse. And they would really go to the patient's house, very much like the old school 1950s doctor would make house calls. But it was not just the doctor that went to the patient's house, it was the whole team transported themselves to the house. And what they showed through this model is a number of different referrals came up through the different visits. So the docs and the different members of the teams were able to realize, okay, well, this patient needs physical therapy, which we don't have. And then they would have the physical therapist come to the house, or speech therapy, or any other kind of service. So whenever they identified these needs, they managed it such that it would be provided in a remote way to the patient. The specialist, whoever it was, would just go to the patient's house afterwards. And even though these findings are not statistically significant, they do show, this would be on the right side of your screen, a slight reduction in hospitalization and use of the emergency department. So it actually showed in a way that perhaps engaging in this at-home care can reduce hospitalizations, which is, of course, a fantastic thing. So certainly an interesting paper that I think is worth quoting. Now, what about us? And I told you what other people do. What do we do? What's the experience like at Penn? And I'll spend the last few minutes talking about that. So this is us. We're a big team, as you can see. Here are our founders, Dr. Matthew Stern and Howard Herdig. They started the Centric in 1982, the year I was born, believe it or not. Yes, I'm 40. And this is what our center looks like. This is Pennsylvania Hospital. Our center is right across the street from it. As you can see, a big center, and we're lucky enough to have all these resources all in one place. You'll see it in the next screen. Actually, no, so it's the next one after that. How do I go back? There we go. But the different services that we have neurologists, of course, and we have a growing number of neurologists, so we're always recruiting new people. We also have a very robust group of physical, occupational, speech therapists, nurses, social workers, counselors, palliative care physicians, cognitive neurologists, and of course a robust research endeavor as well. And we think it works great because everybody is there. We're all physically in the same location. And in a few slides I'll show you. And it's just very easy for each of us to pop in and out whenever a patient comes in. And it's sort of the idea that we created of this clinic called the COPE Clinic, which stands for the Comprehensive Parkinsonism Evaluation Clinic, which is the next slide. And you can see it here. So this is our model. This is how it works. Usually, or it used to be before the pandemic, only an in-person sort of approach. But now, since COVID-19, we offer a different modality of services. So we offer fully virtual, fully in-person, or hybrid. So sometimes patients come in for the physical, speech, and occupational therapy part, but are seen by the docs remotely to minimize the burden of travel. So any of those models now we do, but this is sort of the organization chart, the way it works. So there's a nurse coordinator who is the master of the whole schedule. And then there's different teams. So there's a therapy team with the different components. There's the medical team, and that's led by myself from the movement disorder side. But there's also a cognitive neurologist, Dr. Irwin, who's sitting here with us, and a palliative care physician. And then I oversee the fellows. So we have 3 fellows who are with us at every session. And they really are the ones who take most of the time with the patients. I run into and out of rooms to see the different fellows, but the fellows really spend most of the time of just talking to the patient and examining them and seeing what their needs are. And then, of course, there's social worker, and there's our trustee Lauren, who you'll meet in a few, and then a research component. And again, it's a system, right? It just works well because we're all invested and we're all in it together. And I think our patients can say the same about, and we always ask them, this is a long day. You've been here for 3 or 4 hours because you've seen all these different people. Do you think this is worth your time? Some patients say no. Some patients say this is way too long. I don't want to do this anymore. And that's understandable. But many patients, and I would say most patients, say absolutely. Oftentimes they tell us we've never known this much about the disease. Nobody spent this much time with us explaining what the needs are. Nobody told us these tricks for swallowing. Nobody told us these tricks to getting out of the chair. So I think largely, and if I had to quantify it, I would say over 80% of our patients are actually very, very satisfied with this model of care and really do think that it's worth their time. And because of that, they just keep coming. The next question is usually, well, when can I come back to COPE? When is my next appointment? The way we work it is usually we see patients every 6 or 12 months, depending on their needs. and they still retain their local neurologist with whom they follow up in a more close fashion. Now, how does it work in our clinic? So the patient comes in. Pre-COVID, they would check in at the front desk, but now that we have this remote version, it can be done virtually. Every team has about 20, 25 minutes. It depends. We can be flexible, but we try to limit it, again, so that the delay is not so long for the patient. Then we have a wrap-up session where all the teams come together and we all discuss the findings, and we come up with a document that we send to the patients, and our trustee Sue here has the task of sort of making it all happen. And then this is basically a conclusion to just summarizing our recommendations and what we think is best for the patient. So this is what I was meaning before when I said we're all in the same place. You can see we have a 4-story building, and we're all there. The first story is all the therapies. The second story is our offices. The third story is the clinic space. And the fourth story is research, and patients just up and down the elevator, basically, depending on what their needs or what they're interested in doing. We usually minimize that as much as possible. We are now seeing patients on the first floor. It's just easier. There's no need for transportation, and we will go to the patient. But if a patient has a research visit, it's just very easy to pop in the elevator and go to the 4th floor. And you can see here that many different referrals come up with this care. So we refer patients to cardiology, to urology, to ear, nose, and throat, palliative care, genetics. Many of our patients are interested in genetic testing, and we have that capability at our center. Ophthalmology, not infrequently, our patients describe double vision, and we have actually a neuro-ophthalmologist who is trained in movement disorders, and it's all in the same center. We also have psychiatry referrals. Coping with these diseases is not easy, as you know. Lots of depression and anxiety, which also happens as part of the disease, and we make those referrals as well. And of course, our therapists themselves also decide when they see a patient, well, maybe this patient will benefit from long-term therapy of some sort, and then those referrals are also generated in that sense. So you can see how it all kind of comes together very nicely. Everybody understands what the different needs are, and we refer patients from there. So just to close, even though we don't have a lot of data right now to suggest that multidisciplinary care makes a huge difference, we know it does. We just need to demonstrate it. We just need that research to prove it. But in a way, we're able to develop this care or continue to deliver this care even in the absence of this data. I don't think it's absolutely necessary to know because we all kind of know. I think it'll only become an issue if coverage from insurance, for example, became problematic. To the point, but to this day, it has never been an issue, and I don't expect that to change. As you can see, there's many different models of care. The different centers do things differently, but I think as long as the overall goal is the same, whatever works for you, works for you. Some diseases, of course, are different from others within these atypical Parkinsonian syndromes, and there are specific needs that each disease has, and I think it's our role to understand those differences, identify them, and refer patients appropriately. I think the best way to prevent these complications is to pick up on them early. And that's why we encourage patients to come to our clinics early so that we can start the journey of understanding what are the things that are starting to emerge. And I'll just end up, because you have to nowadays, saying that COVID is not a barrier for the delivery of care. We now have the resources to deliver care remotely or in a hybrid fashion. So not being able to get out of your house should not be a reason not to get the care that you need. So I'll end there. This is the front of our building, and I look forward to the Q&A session. Thank you.
Can you give me a little more detail about what's involved with swallow studies?
Sure. So there's different types of swallow studies. The ones that we usually refer patients to are video swallow studies. Basically, the patient drinks contrast, barium usually. And through the X-ray machine, there's a video that shows how the contrast goes into the mouth and down the throat. And we can tell where things are not running well. So when I say we, it's really speech therapists. They're the ones who are trained to understand these tests and interpret them. Again, multidisciplinary care, right? But what they do is they see where the problem is. So where in the swallow mechanism is it the front of the mouth, the back of the mouth, the early throat, the back of the throat? where the dysmotility or where the problem is. And some of these dysmotilities are treatable, whereas others are not. The ones that are not treatable, of course, that doesn't mean they're not manageable. There's still ways around it once you identify what the problem is. But some of the problems can actually be fixed. So that's why we always encourage doing these tests, because if there's something we can fix, we don't want to miss that. You want to really identify the things you can fix, and the things that you cannot fix, you want to learn how to get around it. Sure. There's another one here. Yes, so we are in Center City, Philadelphia. The question, by the way, is where is the clinic located? We're in Center City, Philadelphia on the corner of 9th and Pine Street. Not a very nice area to park, I will say that. And I think the number one complaint we get is like, you have no parking. Which we do, is just a little far. It's 1 block away from the clinic. But we have valet service, so even if you don't want to park in our designated parking space, you can pull up right up to the corner of 9th and Pine, and a valet service person will greet you outside. They'll take your car, and then they'll give it to you when you're done. It's a 4-story building. It's right across the street from Pennsylvania Hospital. So it's the northwest corner of 9th and Pine.
So then do you work with the neurologists at Providence?
Correct. So we are actually removed from the main Penn campus, which is a hub at 34th Street. So movement disorders, historically, again, since it was founded in 1982, it was founded outside of the main campus. And because we have been able to build this center that has so many resources, we've never moved back to the main campus. That's not to say we don't belong to the main campus. It's just geographically removed. But yes, it's the same thing. Yeah. There's another question here in the back.
If you could wait till Oscar gets there with the mic and say it into that would be great. Thank you.
How do you, what's the procedure to make an appointment for the COPE clinic?
Oscar, can you turn the microphone
I can
on?
repeat the question. So the question was, what's the procedure to make an appointment at the center? Well, there's many different ways. If you are a patient who has established care already at our center, then your treating neurologist can make a referral to us. If you receive your care outside of Penn and would like to be seen at the COPE clinic, then there's a phone number, in case anybody wants to write it down, 215-829-6500. And basically, you give a call and ask for an appointment at the Movement Disorder Center at Penn. They will schedule you that way. Sometimes, though, when you do that, they'll schedule you with a regular neurology, like not neurology, movement disorder appointment as opposed to the clinic itself. So if you ever, and that's fine. You can see one of the movement doctors at the center if that's what you want to do. But if you want to be seen at the COPE clinic and not see movement disorder specialist because you have one already or whatever other reason, then just make sure that when you call, you specify that you are in contact with Sue Reichwein. So Sue currently coordinates our clinic, and she can arrange those evaluations with you without having to see a neurologist first. So we just expedite the process. Sue, do you want to add anything about that?
No, unless you want to give my number, which I'm happy to.
What's your number? 215-829-7273. So that's the magic number. Use the magic number. Another question?
If you don't, sorry everyone, just quick announcement. If we could do the questions into the microphone, number one, so everyone could hear it, and number two, because we're also recording this to show virtually for people who couldn't attend today. I should have said that earlier. Thank you. Sorry.
That's okay. What's the appointment like? Once you make the appointment, do you have the team come in and do an evaluation and then refer to what you deem necessary?
That's exactly right. So patients arrive usually around 9:30 a.m. Am I right about that? And they're usually first seen by the therapy sessions. So they get physical, occupational, and speech. Then they're seen by the medical team, the fellow in particular. Then they might, in between waiting for the attending to come in, which is me, they might see palliative care or social work or counseling or all of the above. And then I usually close the day being the last person to see them. So usually the patients are out by around 1:30. So it is 3-4 hours that the patient is there, and we usually are very explicit about that. Now, it doesn't have to be 4 hours. Some patients who just don't think that they can really stay in the clinic for 4 hours, we ask them, well, is there a specific service you're looking for? Like if there's a specific provider that you would like to spend most of your time with, we can make an abbreviated version so that you're out of the clinic sooner. But of course, we always like the input of all of our members. So if you want to the whole COPE experience, then it is about 4 hours.
Thank you so much, Dr.
Oh,
Deik.
sure, my pleasure.